From the San Francisco Public Press, you're listening to Civic.
My existence and the existence of other people like me is being turned into a platform for people to campaign on. I am not a political pawn.
He's 15, a sophomore in Oakland, a runner, a scout. And he's anxiously tracking federal government actions to take away his medical care. For years, major medical associations have said that gender-affirming care for adolescents can reduce depression and suicidal thoughts when carefully monitored. But federal health officials say that care is unsafe, and they're moving to restrict it nationwide.
We're done with junk science driven by ideological pursuits.
No new law has passed, no final rules are in place, but through executive orders, funding threats, and policy declarations, Washington has already reshaped care in exam rooms across the country.
You don't have to ban something outright to restrict access to it. You just have to make people afraid.
In this episode, who decides what counts as medicine? Doctors, families, or federal agencies? I'm Sylvie Sturm. This is Civic. Government policy can often feel distant, buried in acronyms, guidance documents, and shifting enforcement priorities. Just bureaucracy in motion. But when it comes to healthcare, that distance can be deceptive. Most Americans may not notice the federal government's recently proposed health policies banning gender-affirming care for transgendered youth. That's because it probably doesn't affect them. Critics say this isn't just about one type of care. It's about governance by intimidation versus governance by law. Through executive orders and funding threats, federal officials have reshaped care. No statute has changed, no regulations have been finalized, yet the threat of action has caused healthcare providers to ask themselves, can we risk it? Some providers have already decided the answer is no. If that approach works here, where does it stop? It began last January. President Trump issued a sweeping declaration.
It will henceforth be the official policy of the United States government that there are only two genders, male and female.
In the months that followed, he signed a series of executive orders targeting transgender rights, including efforts to block gender-affirming care for anyone under 19. For decades, clinical guidelines have supported treatment for carefully evaluated adolescents. The care often starts with counseling, then social transition, like name and pronoun changes, and in some cases, medications, such as puberty blockers or hormone therapy. Surgery for minors is rare, and the number of people who receive this care is tiny. Estimates suggest roughly 1% to 2% of U.S. teens identify as transgender, and only a subset pursue medical treatment. Families affected by these bans have been asking urgent questions. Will care be available? Or will hospitals decide it's too risky to continue?
My name is Eric. I'm 15 years old. I'm a sophomore in Oakland High School.
Eric runs cross country. He's a scout. He's thinking about track season. He also started hormone therapy in 9th grade. Eric came out twice, first as non-binary in 4th grade, then again in middle school.
I realized in 8th grade that maybe I felt more like a boy than just non-binary.
Puberty changed things.
As my body started to change, I realized that I did not like that, and I wanted to try and change in different ways. I realized that I wanted to transition medically.
Eric's mother described watching her child navigate puberty before accessing medical care. She asked that we withhold her name for her son's privacy.
I did see how uncomfortable his body was making him. And I did see the lengths that he was having to go to sort of adapt to this changing body that was going in the wrong direction for him.
She said she worried that without intervention,
that process was going to get worse and that it was going to start to cause him more mental anguish.
For her, the decision came down to trust.
Because the way that he's going is making him unhappy.
She described feeling fortunate, both because of where they live and the support around them.
We've always felt really lucky because Eric is an incredibly even-keeled and just really mature kid. And we live in the Bay Area. We have a big supportive network of family and friends.
Eric started high school already transitioning socially. He says his peers adapted quickly.
I was able to kind of have no trouble using the boys' locker rooms or bathrooms. It is definitely evident in how much easier it is for people my age to adjust to different pronouns. I did have some problems with teachers who would misgender me frequently, but overall, my friends and my classmates were actually not much of an issue.
Even in that supportive environment, a new fragility has set in. It was November 20th, the day after International Transgender Day of Remembrance. Sutter Health, a large Northern California hospital system, quietly informed families it was halting puberty blockers, hormone therapy, and other gender-affirming care for patients under 19. Days later, more than 100 teens, parents, and allies gathered outside a Sutter building in Emeryville. Eric was there.
Many people who are arguing for small government are trying to say that government should have a voice in my medical decisions. My personal medical decisions that I spent months consulting with my therapist, my parents, and my doctors about.
For him, this wasn't theory.
I wonder why a group of people who know nothing about me or my life should get to stand in the way of my future because they refuse to have empathy for anyone except people exactly like themselves. I know it is not always easy to fight back, but trans healthcare saves lives.
Then he widened the frame.
My existence and the existence of other people like me is being turned into a platform for people to campaign on. I am not a political pawn.
Soon after the protest, Sutter signaled it would delay the cutoff, for now. For a moment, it felt like momentum.
Delaying their decision to pause gender-affirming care, that was a real oh, okay, what we're doing is actually making stuff happen.
But temporary pauses aren't guarantees. In quieter moments, Eric says the stability feels fragile.
It is iffy. Anything could be taken away from me, testosterone is a controlled substance. If my doctors aren't allowed to prescribe it to me anymore, that is an issue. And that is something I have to worry about. Find some way to get this thing that I really need to live my life.
Eric isn't the only one watching what happens next. In California, state officials are pushing back. In August, Attorney General Rob Bonta announced a lawsuit filed by a coalition of 19 states and the District of Columbia. The goal: stop the federal effort to block access to gender-affirming care for patients under 19.
Including 18-year-olds who are legal adults in California with the right to make their own healthcare choices.
Bonta says the federal government isn't just issuing statements, it's investigating providers. He points to directives issued by the Justice Department under Attorney General Pam Bondi. Those directives labeled gender-affirming care as fraud and instructed federal lawyers to pursue the doctors and hospitals providing it.
Rather than spending their resources on going after elder fraud, cyber fraud, fraud against members of our military, or any number of examples of actual fraud and exploitation, they put their might behind going after doctors and medical providers just trying to do their jobs.
Bonta says this isn't abstract.
US DOJ has subpoenaed more than 20 doctors and clinics and threatened other providers and healthcare institutions with civil and criminal prosecution.
In response, courts have blocked or paused parts of the Justice Department's efforts, for now. Even so, in December, Health and Human Services Secretary Robert F. Kennedy Jr. announced new steps that could penalize providers who continue offering gender-affirming care to young people.
This morning, I signed a declaration. Sex-rejecting procedures are neither safe nor effective treatment for children with gender dysphoria.
Kennedy framed the move as a scientific correction.
This is not medicine, it is malpractice. We're done with junk science driven by ideological pursuits, not the well-being of children.
Alongside Kennedy was Dr. Mehmet Oz, the former television host, now leading the Centers of Medicare and Medicaid Services. Oz pointed to an internal HHS report as justification.
Many physicians as well have been pressured into compliance. The white paper outlines this. And because often in medical school you're taught to go along to get along, they have not been willing to rear their heads and bravely say what they know to be right, which is that these procedures are wrong. Individuals who question their sexuality are treated by many medical professionals on the fast track, resulting in drastic interventions that merely increase the distress they're already suffering from.
Dr. Jack Turbin is a psychiatrist and a researcher at UCSF who studies the mental health of transgender youth. In a social media post responding to the report, Turbin said it reads less like science and more like strategy.
Rather than undertaking a serious analysis of the medical literature, HHS assembled a group of report authors that included a political scientist from a right-wing think tank. The report contains an egregious lack of understanding of psychiatric medicine.
Turbin argues the report was written to justify a policy decision already made. And inside HHS, that policy was moving forward.
CMS is proposing 2 new rules. The first rule will bar hospitals that participate in Medicare and Medicaid from performing these dangerous and harmful procedures. The second rule prohibits the federal Medicaid dollars from funding sex-rejecting procedures on minors.
The message is straightforward. If you want federal funding, you cannot provide this treatment. And because almost every hospital relies on Medicare and Medicaid reimbursements, critics say that would function as a nationwide ban without ever holding a vote in Congress. It seems that all parties agree on one point that Oz made during December's press conference.
Do you know what you get when you mix politics and medicine? Politics.
UCSF psychiatrist Jack Turbin pretty much agrees. In a social media post responding to the report, he said politics drove what he called the pseudoscientific study.
HHS wanted the report out ASAP, presumably to support the political goals outlined by Trump's executive order related to gender dysphoria. This was all about politics, and thus science was sacrificed.
And for Eric, the federal government's reasoning seems dubious.
I mean, I don't think they actually care about kids. I mean, they don't make tighter gun laws. They allow kids to have to worry about being shot in school. They make it so you don't have to get all those mandatory vaccines, so kids can get sick from diseases that we shouldn't even have to worry about anymore. But trans kids, they don't care about protecting us. They just want to use us to convince other people to vote for them.
Eric's mother highlighted other inconsistencies, like different standards for cisgender minors.
An NIH-funded study showed that something like 90% of gender-affirming top surgeries are actually performed on cis boys who have breasts that make them uncomfortable and make them feel not masculine. And as far as I know, Kaiser and UCSF and Stanford are all performing gynecomastia surgery on those boys.
She also pointed to cosmetic procedures that remain available to cisgender girls with parental consent.
Breast implants, which minors, cisgender girls, are allowed to get with their parents' consent. So would I give my cisgender girl breast implants if she felt like she was too flat-chested and didn't feel like enough like a girl? I probably wouldn't, but maybe if she begged me hard enough, I might, and we had a discussion. Do I think the federal government should decide whether or not she gets those? No. It's the same situation here.
For her, that contrast suggests the hardline approach isn't about safeguarding children. It's about signaling out one group.
The minute you mention trans kids, then it's like a disaster.
This story can feel dense. Executive orders, funding rules, lawsuits, mounting regulatory pressure. But strip it down, and it comes back to something simpler. If agencies can condition funding, reinterpret civil rights, and launch investigations to steer care in one politically charged area, what stops that strategy from being used in others? That's where this story turns next.
I'm Dr. Tatiana Moulton Santiago.
Moulton Santiago is the Chief Strategy and Workforce Officer at San Francisco Community Health Center. She said the danger isn't just new regulations, it's the chill that sets in ahead of it.
You don't have to ban something outright to restrict access to it. You just have to make people afraid to provide it, afraid to seek it, afraid to fund it.
She told me she's disheartened that some major Bay Area providers, including Stanford and Kaiser, have already moved to restrict care for trans minors. In some cases, appointments were canceled and families were told services would end.
It really leaves a bad taste, both personally and professionally.
For Moulton Santiago, the stakes are also intimate.
I am a Black woman of trans experience myself, so this work is very personal to me.
She sees what she calls a coordinated pressure campaign.
There's been executive orders that have set a tone, agency guidance that shifts interpretation, and enforcement rhetoric that has created a lot of ambiguity.
Ambiguity that breeds fear because most of the clinic's budget is federally tied.
We operate in a federally regulated ecosystem. We receive Section 330 funding, we participate in federal programs, and that creates vulnerability regardless of what city or state policy says.
That leaves providers weighing medical necessity against legal risk.
We're having providers who are having to vacillate between those decisions of what are the policy implications, what are the legal implications of providing medically necessary care.
She calls the toll on clinicians profound.
Distress and burnout and these types of considerations where they would not have had to make these considerations pre the Trump administration.
And when formal systems hesitate, patients don't simply disappear.
They translate into realized harm for the communities where we have seen Black market silicone, Black market access to hormones.
Moulton Santiago said gender-affirming services are not a niche or elective service. They're the kind of routine, ongoing care that helps prevent mental health crises.
Gender-affirming care is primary care.
When clinics scale back the treatment for patients of all ages to avoid potential federal funding penalties, the fallout reverberates throughout the broader health system.
It should matter to everyone because it impacts us all.
Mental health crises escalate, and already stretched public hospitals absorb the fallout.
There's no way you can remove an entire population of people and not think that it's going to impact both the financial systems, but also the resources of community. What we will see is increases in ER visits. What we will see is the increase of suicidal ideation.
Part of the issue for Moulton Santiago is how are local powers going to withstand the political pressure? At the University of California, which operates UCSF Health, leaders issued a written statement after the federal announcement.
The Trump administration announced proposed new regulations on gender-affirming care for minors. The university is reviewing the proposed regulations and any additional available detail as we assess the potential impact on UC's clinical services. We will continue to do all we can to support the interests of our clinicians, patients, and families, and the dignity of all members of our community.
In early February, Moulton Santiago went to San Francisco City Hall to spell it out.
San Francisco has always led. From the AIDS crisis to marriage equality to sanctuary protections, this city has never waited for permission to do what is right.
At a meeting of the Board of Supervisors, Moulton Santiago put numbers to what providers are already seeing.
The data is unambiguous. Youth receiving gender-affirming care have 73% lower odds of suicidality. In states that have enacted bans, suicide attempts among trans youth increased 72% in the first year alone.
Lance Toma was also there. He's CEO of the San Francisco Community Health Center. He told supervisors that consequences have already landed.
San Francisco Community Health Center was targeted within a few days of the Trump administration taking office, with our trans-focused CDC funding terminated outright because of the executive order on gender ideology.
Toma urged supervisors not just to condemn federal action, but to encourage others to resist precapitulation.
We look forward to you for your explicit commitment that prematurely complying and anticipatory obedience to the rules and laws that do not apply to us in California will not be tolerated here in our city and county of San Francisco.
Moulton Santiago put it in starker terms.
That is not legal caution. That is abandonment, and our young people are paying for it with their lives.
Toma and Moulton Santiago appeared before the board to support a resolution introduced by Supervisor Connie Chan in January.
To reaffirm San Francisco's commitment to the rights of our transgender, gender nonconforming, intersex, and two-spirit San Franciscans and their access to medically necessary health care, including gender-affirming care.
Chan made the legal position explicit.
Let us be clear. Legal scholars have confirmed that there is no current federal law that prohibits gender-affirming care for children and adolescents.
A representative from the Rainbow Families Action Advocacy Group sharpened the stakes.
The big question here is, can an authoritarian government tell us how to take care of our children in San Francisco?
Zooming out for a moment, even if cities reaffirm their values, and even if hospitals hold the line, the real test may come down to whether federal agencies actually have the authority they're claiming. That's where the fight moves next. Kennedy says the federal government has the authority to do this, but federal agencies can't just announce a rule and enforce it. I spoke with Dale Melchert, a staff attorney who focuses on transgender health law.
Agencies can't just act arbitrarily. If they're going to take a drastically different position from the prior regulation, they have to explain how or why.
They must also open it to public comment. Anyone can submit research, data, legal arguments.
Agency is required to read all of these comments, distill them, then propose a final regulation that takes into account the comments that were submitted.
If the agency ignores substantial evidence or fails to respond to major objections, a court can strike down the rule as arbitrary. CMS is invoking something called conditions of participation, the rules hospitals must follow to receive Medicare and Medicaid funding. Historically, those standards focus on safety, infection control, staffing, emergency preparedness, but CMS does not get to decide what counts as medicine.
CMS is not authorized to exercise any supervision or control over the practice of medicine. It is unprecedented.
Melchert said the change also conflicts with Medicaid's requirement that states cover medically necessary treatment for children.
The proposed rule also violates the CMS claims without sufficient evidence that affirming health care for trans youth poses a risk of harm to children and therefore is not effective, efficient, or in their best interests, but disregards the harms from untreated gender dysphoria, which are tremendous.
He says the department tries to get around that obligation by changing the definition of gender-affirming care itself. It argues that the treatment does not meet professionally recognized standards of care,
and hence is not subsumed under the term of the practice of medicine.
In other words, the agency says this isn't medicine, And if it isn't medicine, regulating it doesn't count as regulating medicine. Malchert calls that circular logic.
It's using its conclusion to justify the premise.
If CMS finalizes rules tying funding to refusing gender-affirming care to minors, he expects immediate litigation. That's the legal fight. But long before a court rules, before injunctions, before appeals, something else is playing out. People are reacting. Hospitals are hedging. Parents are panicking. Across the Bay Area, therapists say the impact is real. It's showing up in exam rooms and in sessions filled with anxiety. Bridget sees it from both sides. Her son is transgender, so she asked us to use only her first name, and she's a licensed therapist who works primarily with transgender adolescents and their families. She says federal interventions are reshaping what's happening in her therapy room.
I've had many sessions with parents where they're crying and confused and just don't know where to reach out for support.
Bridget often works alongside medical providers, helping families process decisions about puberty blockers or hormone therapy, and supporting teens through those changes emotionally. She says families are now asking questions she didn't hear a few years ago. Will prescriptions be interrupted? Should we transfer care? Do we need to move? And teens absorb that insecurity. Some respond with anger, others shut down.
Developmentally, they shouldn't have to be dealing with this type of stress and worry, and healthcare should be available to all people, no matter who they are.
As a mother, Bridget remembers how different things felt when her own son first accessed care.
We were just very lucky at that time. It was quite easy to get into UCSF. We had to go through several interviews and make sure that he was ready and really an appropriate candidate for HRT, but he was able to start high school using his new name.
But even that stability didn't last. When Trump was elected again, the timing forced a decision Bridget never expected her son to make.
It just happened to be when he was applying for school, so he applied to attend college outside of the United States.
It meant international flights instead of weekend trips home, and crossing a border with documents that don't match who he is.
He currently travels with a mismatched passport.
A passport that still lists him as female. That's because the administration's executive order defining sex as assigned at birth ended the flexibility people once had to update their gender markers.
He says it doesn't bother him.
She said they were lucky. They could send him abroad. Others can't.
I'm grateful he doesn't have to live inside of what I think many are saying is a genocide against trans people in the United States. And I know that's a really strong word and statement.
Until final rules are issued, hospitals exist in a gray zone. And in the long stretch between proposal and court ruling, institutions must decide whether to wait, resist, or retreat. For Eric, it's simpler than that. It's whether he gets to become himself.
When someone misgenders me, I think about that for the rest of the day, and it does bring my mood down. If that's all the time, every day, that would definitely be super detrimental to my mental health.
I'm Sylvie Sturm. This is Civic. Civic comes to you from KSFP LP 102.5 FM in San Francisco, a project of the San Francisco Public Press, a nonprofit investigative newsroom. Our theme music is by John Dillon. Additional music was supplied by the Blue Dot Sessions. Our team includes Executive Director Lila LaHood, KSFP Program Director Mel Baker, and Director of Development and Partnerships Lisa Rudman. Thanks for listening.